Hi everyone, I'm Karen Gorman. I'm going to be your panel moderator today. I've got two objectives here. One is to get some lively discussions going with our panel members, and the second is to keep to our 40-minute scope. Bit of background about me. I work in the Blue Prism Cloud team, in the healthcare team here in the UK. I've been in digital transformation, working in the healthcare sector for the last 14 years, working closely with acute mental health and community trusts. So I'm keen to get lots of good conversations going. I've got a great panel here today. Welcome Dr. David Mendelsohn, who's the Associate CMO at Mount Sinai Healthcare Providers. We've also got Ben Berkowitz from Partners Healthcare, a massive organization in Massachusetts that covers 75,000 employees and 13 hospitals, and is also the medical training school affiliate for Harvard. And Mark Hadwin from University Hospitals Morecambe Bay, here in the UK for the NHS. Morecambe Bay covers 1,000 square metres up in the north of England, for those that aren't in the UK. So I'm going to kick off the discussions by really opening up to you three about what stage you're at with your automation and what areas you've been covering. So Ben, can I come to you first? Do you want to give us an outline of where you've got to?
Yeah, absolutely. And thank you so much for having me today. Really excited to be back at Blue Prism World. Last time I spoke with this crowd, we had just started our journey a year ago. And I'm happy to report that we've come leaps and bounds since. We now have over 20 automations in production. We have stood up a center of excellence, which is what I'm running. We call it the Department of Intelligent Automation, or DIA, which is in charge of essentially running all of the Blue Prism application functions, as well as vetting all of the potential opportunities that come across the enterprise. We're live in 7 different departments right now with embedded developers, or we call them automation developers, in those departments. They include health information systems, revenue cycle, HR, finance, supply chain, our physicians organization, and research management. So we have a wide variety of automations that are being deployed across our organization, right now mainly in the administrative areas, but starting hopefully as things settle down post-COVID, moving into more of the clinical and clinical administrative areas at the hospitals themselves.
And have you been able to measure what the time you've been saving through these automations?
Yeah, so we actually, we measure on a couple of different levels. First, we measure numbers of hours saved, and we have some thresholds around what gets approved by our steering committee for deployment or for build. Another way of measuring that is translating it into dollars in terms of FTEs or dollars saved based on the average salaries. We also are measuring sort of increased revenue or accelerated revenue. Some of the automations that we have can reduce, or we've seen them start to reduce, some of our denials because we're more efficient and more complete in terms of submitting the claims to various insurance companies or to the federal government. And so therefore, we're accelerating the revenue that we would have gotten otherwise. So we're starting to see some of those benefits trickle in right now with some of the automations. We also measure employee satisfaction, particularly in areas where there's high turnover. We talk about the soul-crushing work that automation can help replace. So, are we keeping people longer in the jobs that they were previously in, or are we redeploying them to work that they enjoy more? So, all of those are elements that we keep track of.
And you mentioned that you've saved something like 20,000 hours during the year. Is that right?
It's actually quite more than that. So we have saved more closer to, off the top of my head, I don't have the number. We have 20,000 hours approved right now that we're working through. I think that was the number that you and I were chatting about, Karen, earlier. So by this time next year, certainly that will be deployed and more, as that's really only a few months worth of work. But it shows how healthy our pipeline is and how much the organization has embraced this technology to really think through how they can deploy it in different ways to enhance the way that we do work. And certainly with everything that's been going on with the pandemic and COVID, we have actually changed some of the automations that we have live currently to help support that. So whether it is changing the way that we're doing taxes or paying our taxes, or changing some of the reporting structure, we've been able to retrofit some of the automations that we have to support the operations in this challenging time.
Interesting. Thank you very much. Dr. Mendelsohn, I'm keen to come on to you to give some outline on where you've got to with your automation journey.
Sure. Thank you, Karen. I wear two hats at Mount Sinai. One is I am the Associate CMIO for the faculty practice at Mount Sinai, and the other is a Vice Chair of Radiology for IT. It turns out both will be relevant to this discussion. Mount Sinai is now a 7-hospital system. We had a large merger in 2015, and we're still going through the efforts to really consolidate a lot of services. Our relationship with Blue Prism really started about 2 years ago on two different fronts. Our hospital IT department licensed Blue Prism and has an internal server and has done some of its own work. And I'm not familiar with all the details of that, but I'll come back to that. Separately, the faculty practice became interested in what was then for autonomy, which is Blue Prism Cloud in essence. Today, we're beginning to converge both those efforts together. I'm going to speak mostly about the Blue Prism Cloud effort that we've made to date. So it goes back about 2 years ago. And what we did was we started with some business development people learning how to develop the automations in Blue Prism Cloud. I actually was not part of the faculty practice role that I hold today at that time. The chief operating officer at the time had a fairly novel thought. He wanted to use Blue Prism Cloud for a patient-facing activity. Quite honestly, had I been there at the time, I might have discouraged that because it took about a year to get off the ground, predominantly because of HIPAA security and confidentiality rules in the United States. That played a large role in our initial kicking this off and developing some automations. It took a little over a year to get through the security issues with a patient-facing solution as opposed to a financial solution where it would be more just moving numbers around on spreadsheets, et cetera, more traditional financial uses of an RPA. With that said, we went live about a year ago successfully in two clinical endeavors. One was something we call the new patient packet. New patient packet would be, and a good example was our obstetrics and gynecology practice would sign up a new patient by phone. They'd schedule an appointment, they'd get some basic information. But as in many places, there's about 10 forms that the patient has to fill out, and that doesn't occur on the first phone call. What we did was we would capture an email address from the patient on that first phone call, and we would use Blue Prism to basically connect with the patient through an email or a text message and bring the patient back into a secure portal where the forms reside. They'd fill out the forms, and then we would distribute the forms to the appropriate practice. And that has been successful in this initial startup in one practice, which is obstetrics and gynecology. It's hard to quantify the total savings at this point, but it's clear that this will result ultimately, as we spread it out to other practices, in diminishing a number of FTEs doing fairly rote email work and distribution of forms. This becomes now of greater interest in the COVID era and the post-COVID era. So we were ready to spread this out into some other endeavors. And then COVID comes along and everything changes. The world changes in New York City overnight. Well, we didn't initially have much of a change in our Blue Prism utilization. But now that we are returning to a live, bring patients into our practices, one of the big issues is how do you minimize patient time in a waiting room because there's still COVID around, patients are scared, staff is scared. What you'd really like to do is have an in-person workflow that moves the patient right into an exam room without much time spent sitting in a crowded waiting room. We thought that one of the ways to do this would be to have the patients fill out forms online. So if you go back to the prior example I gave you, we already had the basic methodology in place. What we've done is rapidly expanded that over the last 2 or 3 weeks as we now go live and bringing patients back into our ambulatory environments. We went live 2 weeks ago with the radiology department, so that, happens to fit my 2 hats. Last week, using Blue Prism, we contacted close to 2,000 patients in a 1.5 week time frame, and about 40% of the patients returned the forms completely filled out with this methodology, and we consider that a significant success.
And historically, then, Dr. Mendelson, would all those patients have come in to fill in the form and sat in a room to do that?
That is correct, and that's exactly what we're trying to diminish. And we are now in the process of developing the same solution set with all of our ambulatory practices. So that's an ongoing activity at this moment. Radiology was the pilot, but we have 5 other practices in active development at the moment.
Brilliant. Thank you very much. Right, Mark, over to you. Last but not least, I know you started your journey with Blue Prism, over 5 years ago?
We did, that's right. We have an on-premise installation of Blue Prism since sort of early 2012, 2013. Predominantly, we used that install, really, which was to support our electronic patient record deployment. So it was essentially acting as an interface between a number of different systems, where processes joining sort of national systems and local systems together, moving information, moving documents around. And those worked pretty well, and we were quite happy with those. And then probably in the last sort of 2 to 3 years, we've really been looking at scaling up our operation, I think, in terms of taking it out of the back, out of the server room and out of the back engine of the hospital, really, and looking at where we can offer more, should we say, direct and I suppose direct access to the bots. So in the last couple of years, we've well, a good one really is our robot that we implemented to help a specialist midwife.
This is the one you made cry, Mark. Yeah,
it is. Yeah, where we have a specialist midwife who looks after all the maternal serum screening, and that involves obviously sending blood samples off to a lab in Newcastle, which is a couple of 100 miles away, certainly round trip, a couple of 100 miles, and getting that information back came back in their system. It was for us to download PDFs and print out documents, which would then go back to the patient. Some of the results we would then upload back into our EPR. And that could take anything up to 2 to 2.5 hours a day, depending how many records, if you like, there were. So we started a bit of a journey, really, with her to work through that process and picking it up in little bite-sized chunks. So we started off just essentially downloading the documents, then we started printing them out, then we started uploading them automatically into the EPR. And that's been really, well, it was had a number of benefits, really. Certainly the 2 hours a day of specialist midwife time that she's not having to do that, but also it's allowed her to do more qualitative checks on the data that goes. Has every mother who we've sent a sample off had a response from the lab, for example. So it's enabled little things like that, which were never really part of our plan on that. So after we'd done that, we then made a case internally to really scale up our RPA journey, and we moved to Blue Prism Cloud. So at the moment we're riding 2 horses. I think long term, I think we'll move everything into the cloud, and certainly with having lots of staff working at home now, it's been absolutely fine for our developers to build the robots sat in their living rooms or their dining rooms, wherever really, and that's certainly been an advantage of the cloud. And really, I think also us moving to the cloud, certainly in the NHS, we've been able to access the NHS Marketplace, which is a number of pre-built, I suppose, automations and processes that other organisations have done. We can take those, and I think we have around about 300 separate computer systems in the trust. A lot of those are common across the NHS, and being able to share even ideas of how we can automate a particular system has been really beneficial. And we've been able to pitch everything into really two themes that we're looking at, one which is patient experience and another one which is staff time and releasing staff time. And certainly some of the David and Ben have just described, how some of the tasks that people do, that can be better spent doing something more productive.
Yeah. So Mark, I guess you're relating quite well to Dr. Mendelssohn's example of actually putting that wrapper around the patient experience and the communication with the patient, which potentially isn't done very well in the UK and the NHS, is it?
No, and I think that's one of those areas that certainly not just in healthcare can catch up. There's a level of expectation, I think, from patients who interact with a number of different other organisations outside of health, and how that interaction is conducted. And I think the NHS is looking to catch up on that, and certainly for high volumes and transactions, where I think we conduct around about 400,000 to 500,000 outpatient appointments a year. Certainly we can improve our communication with the patient in the run-up to those appointments. Certainly we can start looking to ask the patients to give us information that will help. So, just little things like telephone numbers, email addresses, those sorts of things, and having those fed directly into the EPR will open doors up for us further down as we then do different automations, because we've got more information and different channels that we can communicate with the patient. And I think us gathering that patient preferences is certainly where our sort of next sort of stage of the journey goes, really.
But with those volumes of appointments, to actually consider, the back office outpatient team doing that communication, it's just unmanageable, isn't it?
It is, yeah. There's currently, yeah, we probably book more appointments than that anyway, because patients will cancel, patients will not attend, rebook appointments where we can. So it's probably, possibly another 100,000 or so on top of that, appointments that we're actually making that don't ever get serviced.
Yeah, absolutely.
So being able to touch base with the patient from that appointment, even asking for confirmation, are you going to come to this appointment? Which is a lot easier to do through texting back, or just clicking a link to say, yes, I am, or no, I'm not, can I cancel it? And using the RPA instance that that we'll have will allow us to then either directly interact with the EPR, or certainly pass it to an appointments booking team who can do something alternative if that's not available.
Well, and improve your slot utilization as well, if you know that people aren't coming in.
Absolutely. I think one of the interesting things that we've seen, we have a consent form which is electronic, which is online, and I think what we do see about that, the numbers of times people fill that form in at midnight, at 1:05 in the morning, and on iPads, on iPhones, means that people live 24-hour days, and certainly expanding our working day using Blue Prism RPA for us is a way of massively improving our patient experience and the patient access to our services.
So I'm going to touch on obviously what's been going on in the world for the last few months and the impact that it's had on healthcare organisations. Dr. Mendelssohn, you mentioned it earlier in your outline. Ben, has it changed your priorities at Partners Healthcare since the pandemic for automation?
So it's interesting sort of how the pandemic has impacted hospitals from a more administrative point of view. I mean, obviously we've lost a lot of our bread and butter ambulatory work, as well as sort of the PCP visits, et cetera. So it's putting a budget crunch on a lot of organizations, healthcare organizations, and partners is no different. I think what's really sort of laid bare is the inefficiencies in the organizations in general. And so what we've started to hear are sort of places where we could deploy RPA and Blue Prism throughout our system that have never really been considered before. So while the clinical staff and all the folks that were doing amazing jobs on the front line were busy doing that, we sort of waited and stood on the sidelines to say, where can we help? And now we're starting to get, some of the answers to how can we help. And it's more of in a post-COVID world, right? Or or helping to deal with the influx of patients coming back in. Many, to Mark's points around scheduling and other sort of repetitive components, are starting to pop up as opportunities for us. So we're very much sort of waiting for the hospitals to be able to take on some of this work and so we can relieve them of some of that work, and they can focus on more patient-focused work as opposed to the repetitive stuff. And that's sort of how we've been thinking about it moving forward. But the leadership's tone has changed, where they, before it was, Blue Prism and RPA and some of the other AI technologies that we have at our disposal were, nice projects to have and really sort of useful to, help with that repetitive stuff that I was talking about earlier. But now there's a much more of a focus to say, we really need to utilize these tools more. How do we deploy them across the enterprise in a much more rapid fashion than what we've been doing before? And what resources do we need to engage to make that happen?
And is that through driving cost improvements?
Yes, so it's about efficiency and cost improvements. So whether, like I mentioned before, I just sort of peeked at my notes. We've saved about 100,000 hours every year with what we have live now, 20 sort of in waiting, and more to come as projects roll out and finish. So there's the cost savings obviously associated with that, and that's trying to close some of the budget challenges that a lot of organizations are facing now. But I also think, as I mentioned before, it's a redeployment of individuals, right? We have people, it's very easy to teach automations or bots how to do the repetitive work, but you can't teach it healthcare. You can't teach it managed care contracts. You can't teach it how to appeal a claim or to reverse a denial. We really, need people to still do that work. So if we focus those individuals who have that healthcare knowledge and experience to be able to focus on whether it's administrative items that need a phone call or some sort of follow-up with an insurer or a patient, or those that are actually directly interacting with patients to help them navigate schedules or rebook appointments, things like that, where you want that forward-facing contact with patients, especially given the uncertainty, especially to give them some sort of person to talk to and reassure them of all the protocols that are in place. That's sort of the larger plan, is to help free up those resources.
Interesting. Thank you. Dr. Mendelsohn, you mentioned earlier, and obviously with the pandemic hitting, just avoiding patients coming unnecessarily into the hospitals. Are there any other priorities that have changed around automation at Mount Sinai?
Well, basically, as Ben just stated, everybody's waking up to learn that there are other ways of delivering service and care. So I think that the pandemic has catalyzed people looking at alternative solutions that they knew were present, but they were just inertial about employing in the past. So remote workforce. Everybody's working remotely. Just our call center, which is several hundred employees, they're all working at home right now. That's not going to be completely maintained, but now there's going to be opportunities for some of our call center workers to remain as remote workers and others to come into an office. And that means we've had to modify some of the technologies that we use in a call center, for instance, to distribute phone calls, answer calls, the information that's displayed to a call center employee. I think what's happened here is that it's just, again, accelerated everybody thinking about new technologies that they can incorporate into our daily workflow. It's a part of practice transformation, actually. With that said, I would hope to see at Mount Sinai that we increase our use of the more traditional automations. So we do have a few financial automations in place. It seems to me that's still quite fertile, the easiest place to extend some of this, and I think we've come to appreciate that. We are now, as I mentioned earlier, converging our Blue Prism cloud with our Blue Prism on-prem efforts together. And the one point I'd like to make to those in healthcare in particular going forward is that if you're doing anything that's patient-facing or involves clinical decisions, that's generally a little more complex than a straightforward financial solution. And our experience was kicking this off that Blue Prism, the expectation that was set was that you could take a business specialist, train them in the automation software, and they could be set free on their own. I'm not sure that that's true if you want to do clinical development. I think you need somebody who has some knowledge of programming type skills, sitting with someone with clinical expertise to work together. And I think that for us has proven to be the best combination for anything that touched clinical practice. And I think it can be very productive, but I don't think we should be naive and assume somebody with just business knowledge can develop for this.
Mark, what are your views on that?
Yeah, I think I'd probably echo what the guys have said there. I mean, for us now, even though obviously the pandemic is still happening, we're looking to recover back to not exactly what we had previously, because video consultations, for example, have taken off exponentially. Really, not in tens of thousands of, but certainly in the low thousands. And we want to maintain those technologies, as David said. These technologies were there, and we were on our plan somewhere. Those have been brought right to the front of the plan now. And how do we sustain that going forwards? How do we not? Well, it's pretty clear that we had technologies that were in use that were not being used, not just in our organisation, but probably across the world.
Yeah.
And getting the most out of those, but they bring different problems as well. So a video consultation is, you need to know, can the patient actually, have they got the technical capability? Do they have a phone? Do they have a computer to actually do a video consultation? And how do you know that? So again, for us, it's trying to tool ourselves up for the future. So part of our patient experience work is looking at what preferences people will have. Is it a preference that if we can do a video consultation with you, would you want to do a video consultation or a telephone? So, a lot of it for us is actually using Blue Prism, but also using patient to feed us and give us information about how they want us to operate in the future. And plus, we have probably tens of thousands of patients who we have built as not a backlog, but have built up through the change in emphasis through coronavirus. Actually, we've got a lot of patients there that we now need to service appointments from. We now need to service back in the hospital. Doing those in bulk in our traditional methods just isn't going to work. We couldn't employ enough people to do it. So we're going to have to do that slightly differently. And we've been looking at how do we communicate with the patient? How do we offer appointments? How do we start trying to organise ourselves so that we can catch up on some of the backlog that's built up? Blue Prism absolutely front and centre for us for that.
Yeah. So using automation to actually communicate with and start planning and prioritising those bookings.
Absolutely, and but also then sustaining that as a method of operation rather than falling back to the default of printing a letter out and popping that in the post, which adds time. And when you've got tens of thousands of transactions to conclude, 2 days, 3 days, you don't want any delays on those. You need to bring that that time span right down to close to zero as you can.
And is managing the backlog an issue for you, Ben, as well at Partners Healthcare?
Well, what I was going to add was, there's two ways of sort of that we think about automation. One is that it's an existing process that needs to be augmented by automation or replaced by automation. It really depends, because we found situations where the automation or Blue Prism can take up 80% of what the workflow is. The other 20% still need some sort of human interaction. But some of the groups that we're working with, the 7 that I mentioned where we're live, they're actually thinking about it a little differently, and we can think about this differently post-COVID. Where are we replacing, or are we augmenting an existing workflow, or is there a new workflow that we can just build an automation to do? And so some of our groups have actually, instead of hiring people to do the work, they've just literally built the automation to do the work, and therefore sort of it's more of a cost offset, right? Because you never had to hire individuals to do that work. But the work was sufficiently repetitive and easy enough to model out in Blue Prism that cost never existed in the first place. Mm. So I think we should be thinking about that in the post-COVID world as we think about what those new workflows look like to support, whether it's getting back to the new normal or any additional new workflows to support institutions, both from a clinical side or an administrative side. How can we deploy digital workers instead of redeploying workforce into that area or hiring new workforce into that area?
Dr. Mendelsohn, is there similar conversations happening at Mount Sinai?
I think for the most part, we're in the process of examining the existing workflows and trying to just find the best ways to integrate the automation to reduce the FTEs doing fairly mundane tasks. Mm. I'm not quite sure that we've yet reached the point. Remember, it's fairly early in our experience. I don't think we're quite far as along as Partners Healthcare is in this, to come up with very novel utilizations, although I would submit that the clinical utilization turned out to be fairly novel. I do think that people are just much more open at the moment to now more rapidly considering the integration of any kind of new technology. There's no one vendor that does everything. So the idea for me is to find the right place for automation, set it in aside our video conferencing. So just for instance, the other thing that COVID did is not directly related to Blue Prism was one of my other responsibilities was for building a telehealth program over the last year. And we were quite proud. We had gone from 5 telehealth visits a week, January 2019, to about 60 in December of 2019. Well, 2 weeks ago, we were doing 5,000 a day. Wow. With the same technology and the same staff. In fact, we may use Blue Prism right now. There's a group of patients, new telehealth patients, if you will, not existing patients, who have forms to fill out. So we may use Blue Prism to send them the appropriate forms so that they can have telehealth visits. I guess the point being is everything here has to mesh together well. You take the best of what each kind of technology can offer and try to leverage that, not overdo it, just have it the right place for it. And that these things become synergistic and benefit everything.
I think that's really key. I think the extent and pace of transformation over the last few months has been unimaginable, but it's actually choosing the transformations that really work and getting them embedded, isn't it? Whether you're using automation for that and then using it for helping you manage that backlog going forward. I'm just trying to keep an eye on the time. I think we've got about 5 more minutes. So I'm going to start wrapping up, and I'll be really keen to ask you all to share your top lessons learned that you would want to share with a healthcare organization that's starting their automation journey. So Ben, I'm going to come to you first. What would you pick as your top 2 or 3?
So I think a couple of really important lessons that have made us really successful in this journey is really getting engagement from all different levels, right? So we automatically had from the beginning, our Chief Human Resource Officer, our IT leadership, and sort of our finance leadership driving the project forward. And because we had buy-in at such a high level, bringing others aboard was a lot easier to do. And, I've worked in healthcare for a long time and throughout the Northeast. And, you know, healthcare organizations are very resistant to change. If you think back to the EMR conversations a few years back, you know, there was a big resistance to change. And so getting the right people engaged early and understanding both the benefits and limitations of the technology, I think is really, really key to success. I don't think we would have been able to expand to as many places as quickly as we have without that buy-in. So that, I'd say, is probably paramount. All the technology stuff and, you know, how you build your COE and put that together, that makes it a lot easier if you already have that buy-in.
Yeah, exactly. Dr. Mendelsohn, what would be your top lessons learned?
I think healthcare is frequently a little bit behind the rest of the industry, the industrial world, in adopting technology. I think we can take the lessons learned, certainly from the finance industry. There's a good need for financial mechanisms and support in healthcare, clearly. And we don't need to be all that different than the other industries have been, particularly finance. I do think on the clinical side, as I've tried to emphasize here, it's a little bit different, and you need to bring the expertise of the clinicians to the table with the people who understand the technology of the automation. And if you can get those two groups to work together well and communicate well, then there's a lot of potential for great success, just better quality of care and financial savings both. So sometimes it's just a quality issue, sometimes it's a financial issue, and sometimes you can achieve both together.
Yeah, brilliant. Thank you. Mark, lessons learned from where you've got to so far on your roadmap?
I think where our automations have worked best are where we've tried to split them down into chunks or phases, and not try and build Rome in the day, but certainly just demonstrate some value of the robot or the process that we put in. And again, you know, the midwife one is probably our most it's successful in terms of a process where we were just able to, in bite-sized chunks, just gradually turn that dial of how much the robot was doing, and that just gradually increased confidence, because it is, you know, is a new technology to a lot of people out there, and when people have been doing something for a long time, even in this case, it's something that she absolutely detested. It was just giving her confidence that actually everything that she was doing, you know, the process is doing, and that worked best for us, I think.
But I guess, you know, that's one example of a clinician's practice that you've helped improve. You must have so many areas within the hospital where actually, once you start digging into it, you've got clinicians not using their hours of their day in the most appropriate way.
Well, interestingly, the lady who we did this for, she actually shares an office, and we'd gone down to demonstrate, you know, the phase 2, I think it was. We just walked her through what the robot was doing, and a colleague who sits next to her does a marginally similar process around newborn hearing screening, a totally different system, and but has that manual interface. So you can guess where the conversation went next. Well, when we finished with Lynn, can I have a bit of that as well? So, you know, so there's certainly a bit of word of mouth, and I think and having clinical advocates as well, because now Lynn is a total clinical advocate for this as well.
Brilliant. Well, this just lets me wrap it up, and thank you all for attending and for your discussions today. Thank you very much for the virtual audience. Once this is broadcast, the panelists will be available to respond to any questions if you want to submit any on the chat. Right, that leaves me to finish off, and thank you and goodbye.
Thank you.
Thank you, everyone.